Good evening, everyone. We'll get just started in a couple of minutes, waiting for our colleagues to join in. Waiting for a minute more to get started. All right. Good evening, everyone. Wish you all a happy new year. This is our grand rounds for 2025, starting today with a bang. It's with a difference. As you would all know that traditionally we have had the grand rounds being presented by our physician leaders, guest speakers from outside, and also fellows. But for this year, for a change, we're going to start with our advanced practice nurse providers and also our executive leaders in nursing. Today is going to be a change, and the change has a story. 3 or 4 weeks back, I was sitting down and thinking about what transformation happened in the cath lab and who were responsible. We brought in some clinical trials in the cath lab, and one thing which we noted was the keen enthusiasm from all our nurses and advanced practice nurse providers, and particularly our executive team, that always was streamlining the activities for our study coordinators. And just to see further the enthusiasm, we had one of the APNs approach us asking for more research work and asking why the research was perhaps required to be more involved so that they all could participate. And that triggered me. Maybe we should ask and see what work they themselves have been doing. And you'll be very thrilled to know that we have brought in today 3 of our own people from our cath lab. I'm going to invite now Minnie Jijo, who's our advanced practice nurse. Welcome, Minnie. Minnie has extensive experience in nursing career. She started 22 years back in Kerala, India, where she had her nursing degree and subsequently had her Master of Science in Acute Nurse Practitioner a course at New Brunswick. And followed by, just recently, she is completed her Doctor of Nursing practice. And with that, she had some specific research interest. And actually, it was Minnie who approached us with a keen interest to do some more research work. And with that, I was very thrilled to know that she has already done some work in her nursing, and she's going to be presenting her with that. So with that, welcome, Minnie. We have the second person joining in is Sandra Vargas. We all know Sandra. Without Sandra, the operational efficiency in the cath lab does not happen. Communication, the key leadership that she brings in is phenomenal. And when I looked at her CV, I was very impressed. She has a series of reckoning in her career, starting with Associate of Nursing of Science in Nursing in Middlesex County Community College, UMDNJ. This is like long time back in 1990s, followed by Bachelor's of Science in Nursing, Master of Science in Nursing, Master of Science as a nurse practitioner, and Doctorate of Nurse Practice. And what she's going to bring to her to us is her keen role and fundamental question of teamwork and the the important role that our advanced providers provide in our teamwork in the cath lab. The third person who's going to join us is none other than Lee Walker. He's our cardiac cath lab electrophysiology operations manager and cardiac same day department operations manager. Lee came actually, believe it or not, I learned it just today. He came from England. So, and he did his Bachelor of Sports Science in England in 1998. And subsequently, he joined in initially when he came here with interest in to being an exercise specialist. And then a switch happened when he pursued his Bachelor of Science in Nursing in 2006 in Philadelphia. And subsequently, now he's pursuing a Master of Science in Nursing with Executive Leadership, which is in progress. And he's expected to graduate this year, and he's going to bring in his role in research. With that, welcome to all three of you. We are very thrilled and excited, and I'm hoping this will basically stimulate a lot of people from nursing and advanced nurse provider background to participate in the same way as all three of you have been doing for the last 3 years or so when I've been since I've been here. And now what we will do is we're going to switch over to Minnie. I invite Minnie to give a presentation. It will be a presentation of 10 to 15 minutes, followed by a quick 1 or 2 questions. The same sequence will follow for all the presenters. And then in the end, if there are additional questions, we'll open up the floor for everybody. With that, Minnie, the floor is yours.
Thank you. Hi, my name is Mini Jijo. Thank you, Dr. Sengupta, for giving me this opportunity to present my project on the implementation of evidence-based intervention to identify risk for contrast-induced nephropathy among our patient population. Before I start, I would actually want to go over the case presentation. A 48-year-old man presents to the emergency department with complaints of new onset chest pain with exertion. He has a history of tobacco use, hyperlipidemia, type 2 diabetes, and chronic kidney disease with baseline serum creatinine of 1.7 and estimated glomerular filtration rate of 47. Initially, he undergoes coronary computed tomography angiography, which demonstrates more than 75% of narrowing of the proximal LAD. The next day, he undergoes coronary catheterization with successful drug-eluted stent placement to an 80% stenosis of his left anterior descending artery. He receives a total of 211 milliliters of contrast derived from both examinations. His serum creatinine level increases to a peak of 2.4 milligram per deciliter at 48 hours after percutaneous intervention, returning to baseline over the next 72 hours. He recovers uneventfully. The treating physician diagnosed him with post-interventional contrast-induced nephropathy. So as you see, my project is actually on acute contrast-induced nephropathy. So a quick definition, acute kidney injury network requires that for a diagnosis of post-contrast acute kidney injury, at least 1 out of the 3 conditions is met within 48 hours after contrast media exposure, which includes an absolute increase in serum creatinine level by greater than or equal to 0.3 milligram per deciliter from baseline, a relative increase in serum creatinine level by greater than or equal to 50% from baseline, or a urine output reduced to less than or equal to 0.5 milliliters per kilogram per hour for at least 6 hours. Risk factors for contrast-induced nephropathy. The primary risk factor is pre-existing renal insufficiency with reduced nephron capacity, diabetes, dehydration, congestive heart failure, severe transient hypotension, advanced age, are other risk factors. Dose-dependent risk with the volume of contrast is something that is significant. Actually, that's what brings the project in. Intra-arterial contrast media administration actually puts the patient at higher risk for contrast-induced nephropathy compared to intravenous contrast media administration. And some of the proposed explanation for this is advanced vascular disease of those patients, manipulation of aorta, microembolization of renal parenchyma, transient hypotension, all of these which are caused by the catheter-based procedures, which then eventually leads to renal hypoperfusion. The incidence of contrast-induced nephropathy after percutaneous coronary intervention varies anywhere between 0 and 24%. Patients with normal kidney functions have low risk, which is 0 to 5%, whereas patients who have underlying kidney disease and one or two of the associated risk factors, their risk increases anywhere between 12 to 24%. This is the third most common cause of iatrogenic acute kidney injury after renal hypoperfusion and nephrotoxic drugs. CIN is underreported. This is because most of our patients leave the hospital 24 hours usually after the procedure, so the peak rise in creatinine is not captured. Contrast-induced nephropathy causes prolonged hospitalization, increased mortality rates, and healthcare expenditure. Following cardiac catheterization in hospital and 1-year mortality increase 2 to 5-fold in patients experiencing post-interventional acute kidney injury compared to those without. Pre-procedural prophylaxis reduces the incidence of contrast-induced nephropathy. So the significance of contrast-induced nephropathy in our site, at our site. So our patients, our cath lab is a high-risk cath lab. So patients that come to our lab have increased hemodynamic disturbances and comorbidities. They do usually have an addition of 2 or 3 risk factors that was mentioned before. The National Cardiovascular Data Registry shows that the incidence of contrast-induced nephropathy at our site is 10% for the first quarter in 2024. The target goal is actually anywhere less than 7.5%. The National Quality Forum, because of increased incidence of contrast-induced nephropathy, set an objective to reduce contrast-induced nephropathy post-contrast exposure. This is why the project was developed. So the purpose of the project was to implement a standardized advanced practice nurse-led screening tool in identifying patients who are at considerable risk for developing contrast-induced nephropathy, with the aim to promote prophylactic therapies and/or referral to nephrology prior to dye-based cardiac procedures in the cardiac catheterization lab. The PICO question that drove the project was, does the use of pre-procedural modified Maron score improve the identification of patients at high risk for contrast-induced nephropathy among patients undergoing coronary angiogram and percutaneous coronary intervention in the cardiac catheterization laboratory, promote prophylactic therapies and referral to nephrology compared to the current screening practice over a period of 8 weeks? So what we basically did is we took a group of 80 patients through convenient sampling, and we used the modified Maron score to, which was actually the risk detection score, to identify patients of high risk for CIN, and then referred those high-risk patients to nephrology. The project design was a between-group analysis, as mentioned before. 80 patients were collected, or the patients were collected through convenient sampling and divided into 2 groups. The pre-implementation group was the group where the risk for CIN was detected through the current screening practice, and the post-implementation group was another 40 patients through convenient sampling, where the risk stratification tool was used to identify risk for contrast-induced nephropathy. This is the instrumentation that was used, modified Mehran score. So the Mehran score was developed by Dr. Roxana Mehran, who is the chief of cardiology at Mount Sinai in 2004 with the aim of identifying patients who are at risk for contrast-induced nephropathy after percutaneous intervention. So the original score was actually developed to identify risk post-exposure, dye exposure. But since prophylaxis now is the key for quality improvement, the tool then was modified by taking out or excluding a variable, which is actually the volume of dye that was used during the procedure. So by removing that variable, the tool was modified, and instead of the 8 original variables, the tool was cut down, having 7 variables. As you can see, it has 7 different variables. Each variable is assigned a weighted integer, and then the total score is calculated, and based upon the score, the patient is then categorized into different category. Low risk is a score less than 5. A score between 6 to 10 is considered as moderate. 11 to 16 high risk, and above 16 is very high risk. For the project, high risk and very high risk patients were referred to nephrology. The frequencies of referrals were compared during the Pearson chi-square test, and the findings were considered statistically significant if the p value was less than 0.5. If you look at the graph, in the comparative group, 5% of patients were identified for having risk for CIN, but in the implementation group, this came up to 13%. So from 5 to 13, there was an 8% increase in patients who were detected to have as high risk for developing contrast-induced nephropathy. So implication of the findings, increased preventive services to high-risk patients can be delivered by identifying high-risk patients through a streamlined procedure, the standardized screening tool. The project also helps to decrease the time for risk stratification and referrals among the advanced practice providers. It promoted streamlining of the screening practice, and it helps to meet the CIN quality metrics, hopefully with the aim of reducing the incidence of contrast-induced nephropathy through prophylaxis, and increased patient safety leads to improved quality care. So summarizing the project, contrast-induced nephropathy is the third most common cause of iatrogenic acute kidney injury. Pre-procedural risk assessment and prophylaxis reduces the length of hospitalization and mortality. Use of modified Mehran score is a golden standard for promoting contrast-induced nephropathy prophylaxis. Future practice change calls for development of standardized prophylactic protocols for high-risk population. Thank you.
Fantastic, Many. Thank you very much for this presentation. I'm going to have a quick question to you. Could you just, based upon your, your insights here in the cath lab, outline to us what is your opinion in terms of what you see we could do to improve the risk of contrast-induced nephropathy? I do not know the latest numbers of how we are doing, but I know that this was a significant concern almost about 1.5 years back when I had come here, and there was some during our M&Ms and other times we were discussing on how we improve the numbers. But what is your opinion and what we could do proactively, given the fact that quality and outcomes this year is going to be critical in terms of metrics that is going to be seen all across the health system?
Yeah, yes, Dr. Sangur. So a standardized protocol would be helpful. We do have a lot of patients, hydration is the key to prophylaxis, but our population, we have a lot of patients who are on fluid overload, like they have heart failure. So that is a challenge when it comes to hydration. So we would need protocols. Currently, we do have hydration protocol. It's 1 ml per kilogram per hour of isotonic saline infusion on patients if their ejection fraction is normal. But we do not have a standard protocol for patients whose ejection fraction is low, who have heart failure or who are in fluid overload. So we would benefit from having a standardized protocol based upon the ejection fraction of patients as well as all the other comorbidities, the risk factors that I actually mentioned in the Mehuran score.
That's interesting. Can I ask a question just to follow? As you mentioned, hydration is important. Do you routinely assess volume status of a patient independent of what they have, heart failure or no heart failure? Because ejection fraction is not equivalent to volume status.
Right.
Person could be IVC, could be completely collapsed. And if you do that, what quantitative method, for example, before a patient goes and you're using? I mean, quantitative means like, do you just, how are you assessing as APNs and physicians about how hydrated a patient is?
Yeah, so we do our physical exam. Each patient that goes through the same day cath lab, one of the APPs see the patient. We examine them, and usually we do put in fluid orders the day before without seeing the patient based upon their EF. But once the patient hits the same day cath lab, we do assess them. And then based upon our assessment, if their EF is normal and they look optimized, like they're not fluid overloaded or euvolemic, we start them on 1 ml per kilogram an hour. And then we cut it down later. Usually we keep them for 6 hours post-procedure if their EF is fine and they look fine. But if not, then we have to cut it down.
I just think I'm just thinking aloud. If a patient is at a high risk, and should there be a method for us to look at the IVC, for example, with a point of care ultrasound quickly, and if it's collapsed, still be able to give some fluids. Maybe some work to be done, but maybe we should be innovative in the way we are hydrating, not just doing a protocol just because it's done, but doing a protocol because something is going to benefit. It's basically related to an individual assessment. More to come on that. But thank you very much for that presentation. And we'll come back in the end if there's more time, and I'll open up for more discussion. Now I'm going to invite
Thank you.
Sandra Vargas. Thank you very much. Sandra, please feel free to join and give your presentation.
All right. Thank you and good evening, everyone. First, I want to say thank you for taking the time to join us in this presentation today. I'd like to thank our host, Dr. Sangupta, for certainly promoting this forum to help support the initiatives in our workplace. So my program is Enhancing the Cardiovascular Service Line with Advanced Practice Provider Collaboration. This was not a quality improvement project, but more or less a labor of love for me. So I'm excited to tell you all about it. Again, my name is Sandra Vargas, and I am the lead APN for our cardiovascular service line. So after review of this presentation, there's hope that you all can identify the 3 essential benefits of our advanced practice provider collaboration, and identify what we look to as our multi-level support practice model that helps to support the partnership and the delivery of care within our service line. So the goal again was enhancing services by delivering the best care and focusing on a patient-centered approach, which is important, both prioritizing efficiency and accessibility for services. And our objectives here were to increasing patient as well as the physician satisfaction, strengthening the support to our nursing team by utilizing evidence-based practices, improving on our quality measures, and certainly trying to attain 100% compliance of the regulatory accreditation requirements. So as we look at the role of the nurse practitioner in the cath lab, first I want to say we have to look at the lab itself. And we have a very complex environment that encompasses a range of varying procedures. We certainly have cardiothoracic services sometimes being provided within our lab. There are quite a few complexities, and that certainly requires support staff and a multidisciplinary approach to services. So when we look at the growth of our lab, I wanted to just share with you what our volume has been. And these are not specific to uh, procedures, but more or less encounters. So we see that in 2023, we were a little over 5,000 cases for cath and EP. And in 2024, we certainly over 6,028 cases. So our volume definitely has grown quite a bit. And that's why we look to enhance services. So how it started. So in New Brunswick, our APNs were being utilized primarily in same day. And they were looking at pre-procedural preparedness, and at times at the request of certain physicians to discharge their patients. So we were performing and documenting all the appropriate history and physicals on patients prior to procedure that were scheduled in the cath lab, both cath and EP. And those H&Ps are required to be completed and up to date. No less than 30 days. It's really important that they are up to date. So many of the nurse practitioners have had to redo the H&Ps. On top of that, they also reviewed pre-procedural. Oh, let me go back. I'm sorry. They had to review pre-procedural labs for diagnostics, risk stratification, as well as look at the appropriateness for procedure scheduled in the lab. We were also facilitating consents for physicians and procedures performed within the cath lab, and certainly discharging patients. So currently now, I'm going ahead of myself, as of August of 2022, the nurse practitioners have expanded their services to include being present in the cath lab holding area. And this has really been the intent for collaboration with the cardiologist in hopes to reduce length of stay post-procedures, identify and treat potential complications by doing tasks and evaluations in a timely manner. So what we've done was the cath lab APN will support the patient looking at all of the orders post-procedure to ensure that the documentation and the plan of care has been expedited for each patient. Each patient has been assessed with the nurse present. We're reviewing vitals, activity levels, TR band, ensuring that hemostasis, vascular hemostasis is obtained, and we're also adding new medications and supporting the reconciliation of their home meds if needed. We're also trying to address acute kidney injury in hopes of either offering the patients IV hydration or oral hydration when acceptable. And then planning for the disposition, whether the patients were to be safely discharged at home or if they required overnight observation or admission. What's important here is that we've had an opportunity as healthcare providers to really sit down and talk with the patient. Did they understand the services that were provided, the education that is required for them to be discharged safely at home? Those are the things that really help to impact patient care and satisfaction. What we've done as well during this current practice is that we've realized the volume and had an opportunity to extend services. So now through a pilot program, still waiting to support the FTEs, but we have clinical support for the nurses and the patients in the evening shift hours. So our lab is primarily done around 7 or 8 o'clock, but those patients post-procedure require that initial assessment. So the hope is that we are keeping a nurse practitioner when the volume permits to keep that nurse practitioner into the evening shift to help to promote patient safety and have that patient discharged or sent to the floor. And of course, when we look at everything that we've been doing, we have to look at quality and quality measures within the lab, because it's important that we look at standards for patient safety to help with our processes and our systems, and optimize the patient team interactions. So studies have shown that collaboration with nurse practitioners certainly has supported quality metrics and improved patient outcome satisfaction. And it's important too that we share, I just kind of like to tell you a little about a few scenarios. So having the nurse practitioner able to sit down with the patient, review the services that were provided, having them have an understanding. So we understand that the doctors, sometimes they're done with their procedures and they are leaving the facility. It gives the nursing staff that clinical support to know that there's more help there in the evening shift or post-procedure. And that's certainly really important. It helps with nursing satisfaction, but certainly patient care. So there was an event that one of our nurse practitioners, it was a phenomenal save that I'd like to share with you. The nurse practitioner was able to see the patient in pre-procedure, prior to procedure, and then post-procedure. Patient was planned for discharge home. Patient presented to look a little differently, um, complaining of left-sided weakness. The patient presented with symptoms. We called a code stroke timely, and the patient was then treated and sent, for an intervention. That was a phenomenal save, and we were fortunate to have, the team present there to support. But it's being able to see the patient pre-procedure and then post-procedure through that continuum of care. And so we're really proud of that. So as we talk about quality, we have to look at our support service metrics that we uphold. So this is actually just recent that we obtained from our cath lab quality data. We've been doing phenomenal. We're looking at percutaneous intervention performance measures, so prescribing guideline medications prior to discharge and ensuring that those orders are in. We're looking at our quality metrics. Are the patients on an aspirin? Their DAP therapy? Is there a statin prescribed at discharge? And then, of course, looking at the creatinine, both pre and post procedure. And as you can see in 2024 second quarter, we've actually been maintaining our numbers and doing extremely well. So as of recently and today, our leadership has shared with us that for patient experience data in the cath lab, as of December 2024, we were in the 99th percentile for nursing communication, doctor communication, and our overall rating as a top performing unit. And that's just really, really exceptional. And that speaks to the current programs that are in our cath lab that we're all really excited about. So when we break down a little bit of, what exactly are we doing so great? Well, we are having our doctors talk to patients. There's enhanced communication. There's enhanced discharge information. The nurse practitioner ensures that there is documentation on every patient going home on the care that needs to be rendered to monitor their puncture sites, their vitals, medication education, as well as ensuring that they have the contact information for follow-up so they can reach out to their doctor should they have any complications. And, if we have to, we'll address personal issues and those care transitions. So we are actually doing very well in our percentile ranking. I'm very proud of that. So in our enhancement, we looked at a Model 3 level approach. And that primarily is looking at the clinical component, looking at the team, and systemically. So from a clinical component, what are we doing here on site to help support all of the interventions? We look at access to documentation, to those resources, to be able to document in Epic. We look at the nurse practitioners are doing a pre-procedural chart review so that it's visual to anyone on the in-house side so that they can see that we're reviewing the charts. And if there's any questions with regards to hemodynamic status or concern. We want to make sure the patient's prepared to come to the cath lab. That's well communicated. There's quite a bit of mentoring, and I'm so very proud of that. We have phenomenal cardiologists that really sit down and answer our questions and give us feedback and are supportive of our professional growth. And we also participate in quality measures, which is just as important, so that we know the whys, why we do what we do, and then we can see the outcome. Our team, we have certainly enhanced the culture. Our presence has helped to support a culture of change. We looked at our roles. We've had to redesign some of our tasks and managing our interpersonal relationships. And that really has been with the nurses and the physicians. The nurses have been appreciative of having that additional clinical support that they did not have in the past within the cath lab holding area. And then, of course, the systemic. So this is the broader support from our institution. And this forum really helps to support that, an opportunity to be able to, talk and do research. And we are acknowledged and supported and appreciated by our senior leadership. So that's our takeaway there. So after implementation of having the nurse practitioner role in the lab, we've enhanced the continuity of care through improved communication, being more attentive to patient care issues. There's been, as you have seen, improved patient satisfaction as it relates to education and the services provided. They have a better understanding of their treatment plan, and we are supporting guideline-directed medical therapies prior to discharge. So as we journey together, we have an impact. This is our team. Actually, I just took this picture this week. I was happy to see them, being collegial and supportive of one another in the lab. So what's next for us in the horizon? This is my wish list. I know my leaders are going to say this wasn't authorized or approved, but this is my wish list. So we look to expand the FTEs to support the volumes and the complexities in the lab. 30 cases may not be a lot to a lot of people, but when you think of complex cases successfully, we certainly do need a little bit more support. My goal is to provide 24-hour nursing care for all those patients within that come through the cath lab. So I'd like to see them pre-procedure, inter-procedure, and then post-procedure, and then onto the floor to make sure that, we are able to support them through their journey in hospitalization. And then, of course, my ultimate goal is to open up a cardiology clinic that supports the community's needs. I think that would really be phenomenal, and that's hopefully to come. We've had an opportunity, and I say our leadership has offered us the opportunity to go visit other sites, and they are doing very similar programs, maybe not to this level, but we've had an opportunity to look at efficiency and having AFib clinics and cardiology clinics to help support the service line is really what we've strived for. Thank you again. I have some references if anyone has any questions.
Thank you very much, Sandra. That was awesome. I wanted to your presentation made me realize that perhaps there is an opportunity for us to I would want to use the word spread out the message of all the important work that is being done in the cath lab that often we do not know about. And what we come to know about is all the verges. So I think I want to just change. I want you to think about about us, how we could do a different setting. Like, for example, I'm just giving an idea. So all the wonderful statistics that is happening from week to week, or people acts of kindness or recognition. Do you think that corridor between the cath lab and the cafeteria, we should have monitors or TV screens where we should be flashing some of this information? Because the information of the goodness that is happening all the work that is going around is not traveling, or it gets buried over by the problems. And obviously, there are lots of challenges, and the cath lab has gone through a tremendous amount of challenges, and there's a lot of work to be done. But I think there's a lot of good work that has happened, like you were mentioning, and we do not know about it. What are your thoughts? How do we change the pH of our cath lab where we talk more about the positivity and less about the challenges and the on the opportunity? It seems like we're always talking about the challenges and opportunity, but we don't celebrate or take pride in all the work that is already being done. What are your
Yeah, I would agree. This has definitely been a celebration for me with all of the changes that have been occurring for the past 2 years and that I've been able to witness and been so very proud of. Um, but you're right. We don't celebrate enough of all of the successes that we are having. They occur day to day, but they're not voiced as well. So, and we do see the verges. Um, I kind of would leave that, and hopefully we can challenge our leaders. I like the idea of educational screens, um, changing the view and the format of what we currently have in the cath lab. Um, our visiting area, where we have our patients sit, it's congested. They are not able to sit with their families. This is an opportunity for families and patients to kind of interact in a healthier environment. The way that they are, it's closed off. It's almost as if we're closed off from being able to grow and to show people what we're doing. So, I mean, we've had some great ideas. We've looked at other facilities. We are sitting down later on this week to kind of forum on all of the sites that we've had an opportunity to visit, and we've looked at their workflows. So it's a work in progress.
Yeah, and Dr. Altobelli is here, and I think the leadership, I'm sure Nancy and other are here. I think this will be a call for all of us to see how best we can showcase all the good work that is going around. It's good to hear about some of the mishaps that happen, but that's the only thing we hear about.
Right.
We don't hear about the good things that happen every day, right? I want some kind of a way for us to be able to disseminate the positive work that is happening. And this may be something that we can discuss later on, but something to think about.
Yeah,
Thank you
absolutely.
very much for the wonderful work that you've been doing and
Thank you.
leading us. And now I'm going to invite Mr. Lee Walker to come over and provide us insight about his work he's doing during his executive leadership course. And a thank you from Maya for the help that you've been providing for the heart failure service. The floor is yours, Lee.
Give me 1 second.
Yes.
You see my screen?
Yes, we can see a screen. You can probably bring it to the presenter mode. It'll be at the right bottom. If you go down at the very bottom near the comments, if you see that, lead. So if you see in the right corner,
Yeah, just
bottom
like
corner,
2
bottom,
seconds.
yeah.
There you go.
Oh, yeah, that's,
Yeah.
you can do that.
All right, good. I apologize about that.
There's also one, the display settings. If you go into the display settings, Lee, I'm sorry for interrupting, and just change it to swap them. Perfect. Thank you. Now it's great.
All right. Thank you for the opportunity for this. Again, I apologize for the small delay there. I thought I had it. So my presentation is on radial hemostasis. So I had the opportunity to do this last year. So I looked at hemostatic absorbent disc application for improved TR band compression time. So again, my improvement project that I took on last year, out of my grad studies, was looking at an improvement project between the cath lab. So I took on looking at our TR band standards of utilization in the cath lab itself. Just a bit of background. We typically use the Terumo TR band for when we close the radial access sites. With this, though, there is still associated risk with arterial occlusion, and that risk is 2 to 30% between patients, and that can happen within a 24-hour period. With the utilization of the TR band, it's a gradual deflation of the balloon cuff of that band. So again, that was looking at my research study. So looking at typically the access sites for the cath lab, physicians use the femoral artery, radial, or last resort is usually the brachial artery. Among this, the radial artery access is fewer complications compared to the femoral access site. And again, when they close this for a diagnostic or an intervention, they typically use a compression band for this. When the inflation for a general diagnostic can be 60 minutes, and then they start to gradually take air out of that band. For a PCI, it can take up to about 90 to 2 hours, depend on the ACT result and the length of the case. And again, the duration of the band itself can be inflated from between 8 to 12 to 13 cc's to gain immediate hemostasis. And just like I said, it can take about typically 1 to 2 hours, could take up to a duration of 6 hours in worst case scenarios. So my research study for this was to look at, my PHOT question was to look if we could actually optimize the TR band, gain hemostatic with the using like a disc, like a hemostatic disc. And this was a short study. I did this over a 6-week period. So with any hypothesis question, any stat of any research is always looking at the review literature. So there's ample amount of literature out there. I started off looking at it's called a RADCOM trial, and that basically looks at the TR band itself compared to just a general like hema clamp on the wrist. And again, the TR band was more superior than that at the time. With that, though, there is still risk of radial artery occlusion. Also, again, with that, the more time that's on with the band, the more problems it can cause. So one of the studies that I really liked was the ARCH study, which stands for Assessment of Radial Artery Complications while Achieving Rapid Hemostasis. So this was a trial that was actually done in Liverpool by Dr. Stable, which practiced in Liverpool heart and chest. And this was actually done in 2020 to 2022. So it's almost time of the COVID era as well. And they were trying to look at better resources in utilizing their patients based on bed capacity in the hospital, looking at how they can still see their patients, treat their patients, especially with the amount of patients coming through that hospital, but also for the fact of bed capacity and get patients home within a 4-hour commute. So this was done, it was a randomized trial, and it evaluated the efficiency and safety of using conventional dressings versus a hemostatic dressing for the radial artery access. So all these patients, there was about 2,000 patients randomized. It was put into there was 700 per category, and patients were undergo transradial access with a diagnostic and interventional procedure. So the outcomes was time to hemostasis, and with the second outcomes was incidence of radial occlusions, bleeding complications, patient comfort, and satisfaction. And again, like I said, there was 7 patients categorized into 3 groups. One was with a conventional dressing with just the TR band itself, with a 2-hour compression. And then there was a conventional dressing, which was just an absorbent pad underneath the TR band itself. And the third group was categorized with a hemostatic dressing. And again, that was all of a 1-hour compression time. So what they found with this is that with the hemostasis dressing significantly reduced time to hemostasis compared to the conventional dressing itself. There was also lower incidence of hemostatic complications with the dressing itself. Higher patient satisfaction was reported, and again, patients were able to recover fast, get up from the stretcher and ambulate. So there was a lot more comfortability within using a dressing. The second review of literature that I reviewed was the STAT2 trial, and actually this was actually done here in Morristown Hospital in New Jersey, and this was done by Dr. Seda and Dr. Safenstein. And again, this was a comparison study, just like the ARCH trial. And again, they were using a potassium ferrate hemostatic patch for the radial artery hemostasis. Again, this was a randomized trial, and there was 443 patients underwent diagnostic PCI procedures versus with this. And again, with the outcomes of this, it was the primary outcome was time to hemostasis. Secondary outcome was his time to ambulation, and incidence of radial artery occlusion, any bleeding complications. So with the STAT2 trial findings, with this, there was, again, between the 2 categories, a typical TR band with inflation between 8 cc's and 13 cc's, compared to having a hemostatic disc under the band itself with 8 cc's. Time to hemostasis was 66 minutes of a mean, and with the TR band, 133 minutes. Discharge delays with the disc was a 16.2 with a TR band 2. That's wrong. And again, incidence of bleeding was with a typical TR band was 67.3. So I actually took this on myself into the small sample size the last year in the cath lab, trying to get physicians on board. We did some education prior to this rollout. I was actually enrolled 87 patients, just outpatients of ours that use this, it's called a StatSeal disc at the time. And we were actually able to utilize the StatSeal right after the access of the radial artery, and we were able to achieve hemostasis within 60 minutes. The air pressure for the TR band cuff itself was standardized at 8 cc's, compared to, again, a duration of 9, 13 cc's, dependent on achieving hemostasis. The challenge that I faced with this was, again, a lot of hesitancy from a few physicians at the time. They like to draw back so they couldn't see that blood return, so the visibility of blood from the TL sheath, especially because the disc itself is applied right over the axial puncture site with a secondary dressing as we remove that sheath. Patient concerns at the time was about the dressing. The dressing stays on 24 hours, so they're allowed to keep that dressing on. It kind of peels away itself left a little scab there at the access site. And then just an operational perspective, some patients didn't have a tegaderm dressing applied, just to really keep that disc in step. So the next steps for this was to address the concerns, target education for the physicians, develop clear patient discharge instructions to ensure compliance. And again, we also follow up with patients 24 hours. We made that call, checked on them with a, how was the disc, the dress, and etc. Is it you were able to peel it away? So listening to the practice of issues, again, the tear band itself, without it, the tear band effectively causes with prolonged time can increase patient discomfort and again risk of arterial artery occlusion. What I found and what with the research is that when you're using a hemostatic disc or pad itself, it reduces compression time, it enhances patient comfort, lowers the risk of vascular complications. So again, proposed intervention as we go forward. We actually just did a retreat this weekend with our staff members. So we're actually now looking at that practice and also protocols of maybe having staff members in the cath lab able to pull those radial shafts. So now really using that application disc and that tegaderm dressing. So the advantages of this is promote faster coagulation, especially when we're using heparin between the diagnostic and the interventions, and also our dual plate lines of medications. Reducing the required pressure or duration of the TR band, again, it's always going to be an ACC based on the disc applied. And then just with the improvement of this is, again, getting patient up, ambulating, and possibly even making a discharge line based on TR bands themselves. So the protocol for any patient with the hemostatic disc, that seal, again, this is an ACC standard air cuff. First 3 Cs of that air is deflated within 20 minutes, and then the remainder of the air can be removed after about 40 minutes. Then the band lays on for an additional 30 minutes without any growth. So you're talking within an hour of complete deflation of that tear band itself, with about 19 minutes of the band completely off, and again, just a slight dressing there. So expected outcomes from this is to reduce time of hemostasis, reduce risk of radial artery occlusion, and secondary is to improve patient comfort, reduce risk of hematomas or infections, and then shorten the discharge time of these patients. And just again, the takeaway points from this research that I did last year was not faster recovery for patients, and again, decrease in the discomfort of that band itself, and to improve the patient's outcome. For nurses, is to streamline the workflows, reduce the workload. Physician, enhance procedural efficiency and safe patient outcomes. And again, looking at the whole gamut is for hospital is cost savings, improve patient satisfaction scores, and reduce length of stay for all of those. So, and just to summarize this is, again, using a hemostatic dressing based on conventional factors of just the band itself, it does reduce hemostasis, minimize the risk of any spasms, radial artery occlusion, and just increasing patient satisfaction. Thank you. Any questions?
Thank you.
Sorry.
That was great. I wanted to ask a few questions because I've not asked this, and perhaps I want to pose this here. So in a typical day, in the outpatient elective PCIs, what percentage of patients are undergoing radial access at RWJ currently, do you think?
So we do have a higher physician providers now that are using typically radial access. I think definitely our outpatients. It's a good 60 to 7% of access. I think the more complex cases that physicians deal with, again, they're generally going for the femoral access. Again, based on their sheath size, based on the intervention they're doing. But we have especially with the younger providers now, we're seeing more providers utilize the rest.
So I think that will be important for us to perhaps showcase as the years go by of how we are doing and where do we land, because particularly in elective, I mean, we have a lot of complex cases that are transferred from outside facilities where you need to have a groin access. We understand that, but particularly for elective patients, if we somehow do more radial access, and accordingly, I think for our lab to think about what we need to do to have more radial work being done in the cath lab. Particularly our recovery base could be more radial friendly because they are much easier to ambulate and quicker to go home. So I think we need to think about how do we modernize the environment of elective procedure through radial access, and perhaps also incentivize people differently to be doing that. So thank you for that information and that more work to be done.
I have a question, Parto.
Yes.
So yeah, this is interesting, and a couple of things that we notice when we see patients later on, they come to the operating room for CABG after a diagnostic that then decided they needed to stay to do it. Not infrequently, and I don't know what the statistic is, but there is, radial artery thrombosis. We know those last for, I don't know, a few weeks and then it reopens, but it's a point to be aware of that. If a patient needs a further intervention later on or doesn't go to surgery, quite often when we scan the arm to do radial access, and I tried to use the arm that's already been poked once, so I damaged the same side. But it's not infrequent that we find a radial artery that is actually thrombosed. That's point one. And sometimes it goes all the way half of the arm up. The other thing is often the hematoma or the bruising is not seen in post-op or post-procedure day one, but probably later. So sometimes when we see a patient day 2 or so coming to the operating room and we see, half of the arm is all bruised up to the cubital area, and some of the bleeding that occurs under the skin deeper enough. So to get to the skin, the bruising sometimes is not immediately visible. And so not a hematoma that's bulging in the arm, but you can see black and blue, and probably be interesting. Patients usually not concerned. They just say, "I have an arm is bruised," but probably in the educational component to the patients to make them aware that if they don't see a purple in the arm the first day, probably happens later on. And I don't know how much it happens later on. This is just from the patients that we see coming for surgery. But that's interesting too, and those bigger sheets and so those are two things, observations that we notice on patients coming to the OR.
So Enrique, what you point out, and I just wanted to make a very quick comment. So I understand, but this is typically not the, I mean, at least in high volume centers, other places, this is not typically the experience. Radial arteries are typically more safer. So what we might have to do if we are experiencing this more, we need to look into the root cause analysis and see what can be done to be able to mitigate and bring us in par with what typically the general experience has been worldwide. So more, I think we have some work there. Yeah, Lee, I'm sorry.
But I don't know, because I doubt that the patients have their arms scanned, with ultrasound, for days or weeks, and there's no need to do that. So it is very possible that some of the, and this is asymptomatic, patient had no symptoms when they have, at least I've never seen yet one that has symptoms related to the radial thrombosis. So it's possible that it's higher, even worldwide, but unless they're scanning the arms, post procedure day 2 or 3, a little bit later, because probably immediately it could be some level of thrombosis. But I tend to think that these also can occur a little bit later, just a little stagnant flow and some thrombus that then continues to develop and clogs the artery.
And Ricky, what is the incidence of thrombosis after the intra-arterial lines that we place in our for patients? Because it should not be any different. I think we should just look into that.
Well, the size of catheters is significant. You know, you guys use, I think it's a 6 French.
Typically, yeah, typically I mean, diagnostic in an outpatient smaller labs, they'll use a 4 and 5. Our providers here use a 6 because they can go right into the intervention itself. Nothing greater than a 6. You make it actually, Patsy, you actually make a good point, because when I looked at again last year, looking at the research, one of the fallbacks was this is post complications 30 days out. And, you know, it's hard to evaluate those patients because they don't want to come back to the hospital. And you make a valid point, like, you know, vascular ultrasound, 30 days out to look for occlusions is a really good thing, except you have to get the buy-in from the patients to come back for that. What I can see in the short term is that, again, what this does is we always think of when we hold pressure, we have to push more pressure on it to stop the bleeding. And the problem is that creates this, it can create a displace of a hematoma itself around the band. So again, the nice thing with having an absorbent a hemostatic disc, especially like potassium ferrite, that actually works with heparin, that you're not increasing that pressure load on the wrist itself, but you are trying to achieve hemostasis. So
maybe I don't know if there's anybody from Interventional in there.
Yes, hi, this is Ashok. Can I have a quick comment? Can you hear me?
Yes.
So as Lee had pointed out, if you look at the literature, the incidence of radial artery occlusion after cath in cases where they actually did ultrasound is anywhere between 4% to 25 or 30%. The reason there's a widespread is we're not looking at them, and they have identified few good practices which will reduce your incidence of radial artery occlusion. So there are 3 most important things that I think we can identify. One is the use of heparin at any point during the procedure. So if you're doing a diagnostic cath, even for a diagnostic cath, you're supposed to give heparin. And if it's towards the end of the case, that is one. Second is patent hemostasis. So we only focus on hemostasis, right? Just like Lee said, some people put 12 cc's a year, some people put 15 cc's a year, and it looks patent. And the problem, it looks hemostatic, but when they check for patency, they're just looking at the pulse beyond the TR band. You'll always feel a pulse beyond the TR band because the most important artery is the ulnar. And if the ulnar is patent, you can still have retrograde flow, and the radial artery may be completely compressed, but you will still have some pulsation. So the right thing to do is do an ulnar artery compression and see if there's still waveforms, called the reverse Barbeau test. I didn't see most providers do that. And it's a tendency in the cath lab is just to feel the pulse in the radial artery, which erroneously you can still feel even if it's completely occluded. And I think this idea of using less compression, less air, might actually have more patency because you are not occluding the radial artery.
So I think there's.
I think it's technique related. Yeah.
Yeah, I think there is a room for a project here.
Yeah, and the other thing is we do not have, like for diagnostic cases, we don't need 5 or 6 French catheters. We have the Terumo 4/5, 4 French catheters, where you can also use 5 French diagnostic catheters. It is a 4 French sheath, but you can use 5 French catheters to that. The ones that we have is a 5/6, where it is a 5 French sheath, and you can do a intervention through a 6 French guide, but we don't have access to 4/5. I think that is one opportunity, and we should also have access to 4 French diagnostic catheters in the cath lab. That way, you can use a smaller caliber sheath in the wrist.
Great. I think we ran out of time. There were so many questions there in the chat box. I wanted to just congratulate, first of all of the presenters today, Minnie, Sandra, and Lee, for tremendous work, because this is additional work that you do beyond your work in the cath lab. So this is really deeply appreciated, and we need to celebrate and really showcase some of this talent. And I think this is also an invitation for all the remaining staff to be part of this innovation that we are trying to bring in. I think you're also bringing a good point here that there is perhaps some information that we can go back and look into that could be project for future. And these dialogues is what eliminates our abilities to take the labs to the next level. And more importantly, I think it also creates an excitement, because ultimately this innovation and research, which really makes a difference at the patient level, is ultimately that helps us stay focused in middle of our days, and is very thought-provoking and also enjoyable. So with that, I think there are some questions. I think Dr. Hamrani had a question to Mani with regards to the NPO status. I think we can discuss that sometime later, because longer the time you fast, the longer the risk for renal failure, and how do we assess the volume status in them. That's a pretty important question, but I think we can discuss that in the future. But with that, we close our session today, and we once again thank you all for staying till the very end, and thank you to all the presenters. Thank you all, and good night.
Thank you.
Good night.
Thank you.